in Paris. It started in 1978, did her clinical internship in medicine, surgery, and diagnostic radiology and residency in radiology in Paris. After that, she moved to US for a fellowship in pediatric radiology in Washington, DC, and clinical fellowship in radiology in University of Texas, Houston. And since then, she's been there in University of Texas, and she got her American Board Radiology certification with that, and then she moved on to various positions there in University of Texas, assistant professor, associate professor, and the current position as professor and adjunct faculty in biomedical school in University of Texas. And she's been a member of expert group on oncosurgery and management of liver metastasis. And she's collaborator and investigator and co-investigator of many funded and academic projects from the same university related to abdominal imaging and management of hepatic and few other malignancies. She's a reviewer of CRC protocols and manuscript reviewer of American Journal of Radiology from 2011. And she's has so many awards and merits to her credit. RSNA certificates, many from 1994. And she has just one less than 100 public invited topics in various peer-reviewed journals. She had chapters in books too. And two outstanding awards for her are she has certification from Rice University in healthcare management, Houston, Texas. And the most important one is she's been nominee for Provost Distinguished Faculty Mentors. So that's a real great thing, ma'am. And it's very nice to know about you. And then I welcome you to this platform and request you to continue with your deliberation. Thank you so much.
Thank you. Thank you very much for your introduction and for the invitation. So I'm going to proceed with my talk. If I can have it. Okay. You still see my screen?
No, you have to share your screen, ma'am.
Share your screen, ma'am. You have to share screen.
Oh, so I have to do it again. Okay. Do you see it now?
Yes. Make it slide.
Oh, yeah.
Full screen, ma'am. Make it slideshow.
Yeah,
yes.
Okay, so it's good. Okay.
Yes.
So you can hear me well. It's good.
Sure.
Okay. So the talk I'm going to do today is really an overall evaluation of hepatic tumors, how to proceed to assess hepatic tumors. The modality that we use for that purpose is really essentially CT and MR. MR, as we know, is a technique that is superior to CT because of a better soft tissue resolution and liver-specific agent. In clinical practice, that is not necessarily totally true because there are other factors to take into consideration. For example, the capacity of the patient to collaborate, the local expertise. So CT and MR are both very important to be used, and the value of CT should not be forgotten. I have a little bit of a problem with my talk. I hear everything. Do you hear an echo as well when I speak?
Yes.
So you can hear, there is a problem, right?
Yes, I think now everybody is muted.
So now it's better. Okay, let me try again. Okay, so basically what I'm saying here is that both modalities are very important. I am going to focus on CT because this is what I know, but because I'm going to talk about characterization of tumors, and talk a lot about enhancement. Everything that I'm telling you, of course, applies to MRI as well. So the diagnostic starts with detection. Detection depends on the conspicuity of the lesion, meaning the size, and also the attenuation in relation to the background. For MR, the signal in relation to the background. That's the key element in our mind, how focused we can be. And that's, to me, a little bit of a challenge. So the conspicuity is directly dependent on the size and on the technical factors. We need to have a resolution, special contrast resolution that is really optimized to look at small lesions. We have to use contrast most of the time, we need it, and that needs to be done also properly, meaning that the rate of injection needs to be high. And for liver, we aim for 5 cc, even though we don't get it all the time, but that's the optimal rate of injection. And I'm talking here about the non-contrast because the non-contrast is very valuable, and I'm going to talk a bit about it, and I think it is underutilized. This is just an illustration of why the image quality matters and how different it can be. So this was a study looking at dose across 4 different sites. If you look at the multiphasic study, which is the scan, the technique we use for liver, site 3, 45 millisievert, site 1, 24 millisievert. So obviously, when we talk about CT at site 1 versus CT at site 3, this is not the same thing. One of them is going to be of very high quality, the other one may not be that good. So when you think of the protocol, the dose is very important. When you look at literature, the material and method and the detailed information about the protocol that has been used to do the studies is really capital, because CT doesn't mean anything in a vacuum the same way MR doesn't mean anything. Is it liver specific or not? So we need to be very clear and very careful about the protocol that are being used in practice and when we look at the literature. Just a quick illustration of why the quality of the images matter. This is the same patient. On this study, the calcification is very fuzzy compared to that one, so there's no question. The quality here is much higher than here. The bolus, an example of why the bolus matter. These are 3 images of the same patient. This is someone who has no endocrine tumor, and you can see that on the first scan, we see the dominant metastasis, but we see numerous little ones as well. The second time, nothing. We see only the big one. And the third time, we see a little bit. So this is an example of the bolus quality. Here, the bolus quality is optimized. It is not on this one, definitely, and not as good on that one. So a suboptimal bolus puts you at risk of underestimating the extent of disease when dealing with vascular metastasis or vascular tumor in general. The non-contrast scan. So here's a patient who has a breast carcinoma. This is the staging study. This image here is not very good, right? The bolus is not great. The attenuation in the portal vein is not very high. So we know this is an image acquired too late. This is a delayed image, and there's not much to say about the liver. On this image, which is acquired during the portal phase, you can see that the attenuation in the portal vein is much better. There is something going on. So we know here that there is disease, but look at the non-contrast, right? On the non-contrast, the extent of disease is much, much higher than what we would have anticipated from the portal phase. So this is a little bit of an extreme case. This is not everyday case, but this is an everyday problem where when we deal with tumor that enhance the non-contrast scan is extremely valuable. The mind is, well, how well do we pay attention? We really don't know what we miss. One way for the liver to limit the misses is to have a systematic approach and go back when you have looked already at the case and you have an idea, go back and check if you have looked at every single anatomic structure, meaning the portal vein, the hepatic vein, the biliary tree. Have I looked at areas that can to be blinded? So on the axial image is going to be everything at the dome or under surface of the liver. when you do that, you're going to pick up stuff that you would not have seen otherwise, which is, for example, an anatomic variant or a small portal thrombus, things that we tend to kind of ignore if we don't look specifically for it. And the areas that tended to be a problem at the time we had on the axial images, now we have coronal and sagittal. So when you look at the liver, please remember to also screen the sagittal and coronal images. They are very valuable. So how do we judge, how do we know that we have optimized the detection? Again, the technique is the key. The non-contrast very helpful, particularly with vascular tumor, and then trying to limit our capacity to forget or not be focused. So now I will go on the next phase, next step, which is characterization. So characterization usually leads us to, we look at the case and immediately we know, okay, clearly it's benign, no problem, or it's definitely malignant, or we don't know. But we usually have an idea just by eyeballing the disease. So I'm going to go across, I'm going to discuss the definitely benign and the definitely malignant. The indeterminate are the problem cases which require consultation, more imaging, if you have a CT, maybe an MR, or biopsy. The definitely benign, I have listed here all the possibilities, and I will discuss a little bit of it. And then the one that are malignant, the malignant tumors, once we think it's malignant, we need to do a bit further and try to characterize the disease in one of two categories, which is adenocarcinoma, tumors like cholangiocarcinoma, metastatic adenocarcinoma of any type, and hepatoma. Hepatoma group are tumors that are characteristic by being vascular and having a washout. So I will talk about that a little bit later. The benign disease, what I want to say about that is that we have to apply very, very strict criteria because there is a significant overlap between benign and malignant disease. So when we say something is benign, so when we call a hemangioma, we have to be 100% sure. Actually, we have to be 150% sure because it means to the clinician that there's no problem with the liver and maybe there will be no follow-up or, this is going to be ignored. So we have to be 100% sure. This is an example of the need to be sure. This is a patient with colorectal carcinoma, staging study, hypoattenuating on the non-contrast, hypo on the portal phase, and it kind of gets smaller on the delayed phase. So what is it? Is it benign? Is it malignant? Or can we say? So I'm giving you a few seconds to decide for yourself. So the report generated for this case said delayed contrast filling consistent with hemangioma. With a little bit of aging, maybe there could be a met also. So this cannot be a hemangioma. It could be actually, but we cannot call it a hemangioma because it's not a typical pattern. We don't see any nodular peripheral enhancement. So yes, it could be a hemangioma, but no, I cannot call it as such, particularly in somebody who has a primary that is an adenocarcinoma. So this patient went to surgery and this was metastasis. At the same time, this is another case of the same clinical setting with a small lesion. There's hypo on the pre, hypo on the portal, on the arterial phase. And on the portal phase, it looks maybe a touch smaller. There's a little dot right here. On the delayed phase, which I don't have here, this was totally unseen. This was totally filled in. So is this a hemangioma? Is this a met? Again, very hard to be sure. I would be tempted to think maybe a hemangioma because of this little dot, but it cannot be called a hemangioma for sure. The same patient at another date had maybe a better bolus. I'm not sure. I mean, sometimes the bolus is the reason. And then here you see that there is nodular enhancement within this lesion, which is seen also on the portal phase and extending on the portal phase. So now with that, I can call it a hemangioma. Without that finding, I cannot be I cannot be sure. I have to leave it open. Another example of overlap between benign and malignant, this patient has neuroendocrine tumor, and it has this lesion that has nodular peripheral enhancement, tend to increase a little bit with time. Is it a hemangioma? Is it a MET? So yes, it can be a hemangioma, but in the context of this disease, we have to be super careful, because hypervascular primary or tumors that tend to be vascular could mimic a hemangioma, and that was the case here. So in terms of the imaging, yeah, it could be a hemangioma. With this context, we have to be very careful, and that was the follow-up, which clearly showed this was a metastasis. So that's really my point, is that if you see a benign lesion, in this case hemangioma, with a typical presentation, go for it. If it's not typical, or if the technique is not optimized, if the bolus is not good enough, for example, you cannot say. So there are a couple of papers on atypical presentation. Hemangioma is a big problem because we see that every day. So every day we are confronted to this characterization, and we have to know what are the atypical presentation. The sclerosed hemangioma is the one that is really interesting because it mimics totally a cholangiocarcinoma. So that's for hemangioma. For cyst, it's usually a bit easier, assuming the technique is good, because with low dose, I can see that a lot of cysts don't look cystic, so they are not very sharp, they are not very hypo. This one is not the best example, but basically here it looks like a very hypoattenuating disease. It's a bit fuzzy, not sure, but if I look on the non-contrast, clearly this is not a cyst. So the non-contrast again is the key if we are not sure. A cyst with a good technique is going to be a cyst, no question, but with a lousy technique, we might have doubt. A cyst can also be the result of malignancy. For example, here, this is a patient who has metastatic colorectal carcinoma, was treated with bevacizumab and responded very well. The metastasis after treatment become pseudocystic. This one, so if we don't know the story, if we don't have a comparison pre-treatment, there's no way to be sure with only a portal phase. Neuroendocrine tumor, again, can be problematic because they can be cystic. So generally, it's easy because there are multiple lesions and there is soft tissue component. Sometimes, rarely, like in this case, it looks very cystic. The other thing for the cyst is if you have a multiphasic study, to see that the lesion, regardless of the technique, does not bulge, it doesn't change at all on all phases, is an argument to suggest that it is either fibrosis, like a treated disease, or it is a cyst. That's helpful to always look if we have delayed images or if we have non-contrast to look at that. So the cyst can, solid lesion may look cystic, so we have to be careful about that. Using the PRIL, using the delayed, and of course, checking the clinical context. Now, this group, the adenoma FNH group, is I find usually, for me, is difficult. And again, if it's typical, like in this case, diffuse enhancement, central scar, fading away on the delayed, not a big deal, right? It's going to be a diagnosis that we can make. But sometimes it's not so clear-cut. So let me show you this. I think oh, good, I can see the, okay. So let me show you this case. So we have two lesions on segment 2 and segment 3, and then there is another one much bigger in segment 3 and 2, so bridging those two segments with a small nodule that is of higher attenuation. As we go, this is later phase. In the later phase, the portal phase, the lesion in 2 and 3 are barely visible. Maybe there's a little scar on that one. And then the one that is bigger is washing out. So is this all FNH, or do we have something else? The delayed images, the FNH, or what we think is FNH, is completely gone. But this one is not gone, it's washing out. So do FNH wash out? Yes, they can. If they wash out, can you just say it's FNH? No. And in this patient, this tumor was well-differentiated HCC, while the other ones were FNH. So very importance of being very careful. Typical, we can call it. Atypical, we really have to be careful. And the problem is this FNH can be confused with adenoma, with HCC, with fibrolamellar. So we have to be very, very careful. So the adenoma, I'm just going to say a few words about it. They are not common. I find they are difficult because they are not common and we don't see that many of them. There are two situations for us. One situation that is easy, if this is a young patient on contraceptive with a hemorrhagic tumor, or if the tumor contains a lot of fat, if the hepatocytes are loaded with fat. When we have this possibility, MR obviously is the way to go to confirm. The risk for the patient, again, is hemorrhage and minor transformation, generally tumors that are 5 centimeters or above. So there are two big categories. The one that is the fatty, they call the fatty type, where the tumor is usually pretty stable across the phases. There is generally some enhancement. And this is very well marginated and kind of amorphous looking. This case, we had an MRI which shows the dropout signal on the outer face. So clearly this is fat, we know it's fat, and it is an adenoma, and that's it. We don't need to do much more. Now this one is also an adenoma, and it's very different. It's more complex. There is enhancement, there is a little bit of necrosis. This one is what is called the cholangiocarcinoma type of adenoma, and they are more difficult to characterize. This is important because, again, the type that is typically looking as a fatty tumor or containing fat is not a tumor that is at risk for this different degeneration. The inflammatory type, which has this heterogeneous pattern, is at risk, and to know the risk, we need to have biopsy and look for the beta-catenin mutation, which lead to an increased risk of malignancy. So not calling FNH or adenoma without being 100% sure is really capital. Liver specific, I'm giving just a little summary here, are very, very helpful. What you need to know, however, is adenoma, in spite of being benign, do not pick up the EOVist. So they behave a little bit like metastatic disease. On the other hand of the spectrum, the benign disease, FNH or regenerating hyperplasia, they are made of hepatocytes that are normally functioning, and then there is a take on the delayed EOVist. So that's really a very helpful tool. So in conclusion, I have been dwelling on the technique and I'm dwelling more on it. The need to not compromise image quality in oncology because of concern of radiation dose. This is totally irrelevant because of the life expectancy with this disease. The importance of absolutely strict diagnostic criteria if you are going to call something benign. And then the importance of looking at the material and methods when you look at a paper, because you are going to be surprised. So I'm going to now move on to definitely malignant or malignant. And in that group, we want to be able to classify the tumor in either adenocarcinoma or hepatoma type. And that's pretty, I would say it's possible with pretty high level of confidence, maybe 2/3 of the time. There are obviously cases where we cannot characterize simply by looking at the enhancement pattern, but 2/3 of the time, it's possible. And then, as I said, the indeterminate group is something else. So the characterization here, I listed everything we can use to characterize the morphology. Is it well marginated? Is it infiltrative? Is there a capsule? Is there calcification, etc.? The background of the liver, is it cirrhotic? Is it normal? Is it fatty? The extrahepatic finding, obviously, and the clinical context, all of that is going to be helpful. But the key is clearly the enhancement. So the enhancement is what we are going to rely the most on. And again, This is true for MR and this is true for CT. So the reason the enhancement is so important is because it depends on the histology of the tumor. It is defined by the degree of enhancement, the intensity, which of course depends also on the quality of the bolus, right? If you have a lousy bolus, then the uptake is going to be minimal. But with a good technique, the degree of enhancement is going to be evaluable. The spatial distribution is the enhancement starting at the periphery, is it starting centrally, is it nodular? All of the things that you know about that we can use to characterize a liver tumor. And what is most important is the evolution over time of both the intensity and the spatial distribution. So that is the reason why we need to do multiphasic study. If we look at one image at a time point, depending on the time point chosen, if it's delayed or portal, we are not going to come with the same conclusion because the pattern evolves with time. So we need multiphasic study to characterize liver tumor. And the temporal evolution of contrast, we know what it means because we know what's happening, right? So it is a resection of the hemodynamic within the mass. At the beginning, within a minute after the contrast administration, the contrast material is in the arterial compartment, but very quickly it diffused to the extravascular compartment into the interstitial space, to the extent that after about 5 minutes, most of the contrast is in the interstitial space. So just knowing that, you know everything, because you know that a tumor that has a large interstitial space will retain contrast on delayed images, while a tumor that has little interstitial space is unlikely to retain contrast and will be devoid of contrast on the delayed images, whatever happened before. Here we know 80% of the contrast is in the interstitial space after 5 minutes, or actually even 4 minutes or 3 minutes. So this is not a new finding or a new concept. This has been described since the 80s by the Japanese, and that's quite remarkable when you think that at the time they didn't have spiral CT, right? It was done on scanning one level, the same level of a tumor. So I'm going to now show or talk about the two different patterns, the hepatocellular type and the adenocarcinoma type. So this case here is something that is pretty typical, and you all recognize it. We can say it's a hypervascular tumor with washout. It's most likely a hepatocellular carcinoma. So what we see in this case is the contrast. There is no contrast on the, the tumor is hypoattenuating, sorry, on the non-contrast, becomes very, very attenuating, hyperattenuating to the background on the arterial phase, and then washes out. So if we try to imagine the dynamic, right, the over time, the attenuation of the tumor in relation to the background, it is hypo, there is a peak, and then it decreases. At no time is this tumor regaining contrast. It remains hypoattenuating. Another example that has a completely different pattern and is an archetype for the different group. Here, if you look on the delayed images, there is a lot of contrast, right? No contrast here, a lot of contrast here. So this case is an example of a cholangiocarcinoma, so a tumor that has a lot of fibrosis. Non-contrast is hypo. It does enhance quite a bit on the arterial, and it retains contrast on the portal. This is a variable issue. Sometimes, most of the time, actually, they are hypo on the early phase. So it depends on the bolus, it depends on the tumor. But the key is the fact that there is contrast on the delayed images. So if I do the same thing and I try to imagine the curve of the attenuation of the liver of the tumor against the background, again, there is a peak, which in this case is during the arterial phase, but then it doesn't disappear, right? It remains this kind of a plateau to characterize the degree of attenuation in this tumor over time. So I'm going to show you again those two cases just to dwell in the concept. This tumor has no interstitial space. This is a vascular tumor with little interstitial space. There are mostly cells. This one is a tumor that has interstitial space, very little cells, a lot of fibrosis, and actually the cells are seen generally at the margin, right? This area that has become a little bit of lower attenuation compared to the arterial phase is the area of cellularity and of disease. So everything fits, right? There is no, it is some, actually we can say it's a little bit of a washout because this is the area where there are many cells and over time the contrast disappear because there is no fibrosis. So a few examples just to repeat the same. This case is the same pattern, very bright on the arteriole, very bright on the portal, hypo on the delayed. We have the same pattern. This time, the peak of higher attenuation is during the arterial and portal phase. This example is a patient with the same type of enhancement, except that we see it only during the arteriole. So hypo, hyper, and then hypo. There is a little rim here that is not enhancing early on, and that you see on the portal and you see on the delayed, and this is fibrosis. So this is the capsule. So this is a hepatocellular carcinoma with a capsule. Again, peak and a delayed, it doesn't increase over time. Another example of the same pattern, hypo, enhance somewhat, enhance a lot, and then again, this is washing out. We lose the contrast on the delayed images. And this time, this is during the portal phase. Another one, I think it's the last one, hypo, hyper during the arterial phase, iso during the portal phase, and again, hypo during the delayed phase. So this is just a schematic rendition of what I just showed you. This is the time, the different phases. This is the attenuation. So it's a subjective look at those tumors. If they are hyperdense, the background, they are above the isodense line. If they are hypodense, they are below the hypodense line. And those tumors, all the one I showed you so far, become very hyper. They are above the background of the attenuation of the background, except on the delayed images where they become hypoattenuating. Now, is it always that easy? No, because that's never that easy. Here, it's a lot more subtle. This tumor is not very vascular, a little bit more contrast on the portal phase. So it's really hard to say, okay, is this a hypervascular tumor? If I stop here, I don't know. But when I see that, I know there is washout. This tumor here is way more hypoattenuating than the normal parenchyma compared to here or here. So it's an HCC which is not very vascular, which is hypodense. On this one, it's even more difficult, right? It looks like there's virtually little enhancement, but if you look on the delayed, again, the area of disease is of lower attenuation than the background. So there is some degree of washout. Can we be sure that it is an HCC? No, but the pattern would tend to put this tumor in the group of HCC. And here it's even more difficult. But again, on the delayed images, we don't have accumulation of contrast. This case is also an HCC, but it reached a point where it's hard to apply this principle and where we know there is an overlap with cholangiocarcinoma or other tumors, but the fact that the delayed imaging does not demonstrate uptake, increased contrast, is an argument for an HCC, but it's not a definite diagnosis. So the same schematic rendition, the time and the isodensity with the background, all the tumors I just showed you, they don't really become hyper. At best, they are iso to the background and they lose contrast. So they all show a loss of contrast on the delayed images, or at least on the delayed images, the attenuation remains inferior to the normal liver. So this is a more scientific look at it. It's not subjective now, it's attenuation measurement, the attenuation value here over time. And all the tumors I showed you, the hyper one or the one that did not enhance as much, if you measure the Huntsville units, you can see that there is always a peak and a loss. So on the delayed, it's always the attenuation measurement is going to be lower than what happened on the portal on the arterial phase. So then this is an example of neuroendocrine tumor, which is exactly the same pattern, right? Enhancement and washout. Now, this is not the only way, the only pattern for neuroendocrine tumor, but this is one that is well known of enhancement and washout, which overlap with HCC. So generally, these tumors are cellular, they enhance more than the background most of the time, not all the time. But the key point is the absence of accumulation of contrast on the delayed images. So now I'm going to go to the cholangio. I hope I haven't lost you. And the cholangio, they can enhance early on, but it's not necessarily the most common characteristic. The most important characteristics is the increased contrast uptake on the delayed images. And that is also very characteristic, this rim of hypoattenuation, which corresponds to the active disease. So an example, hypo, some enhancement on the arterial phase. For example, here there is enhancement, which we kind of lose on the portal, but on the delayed, this is really a slab of very dense tissue. So we know it's fibrosis and we know there is accumulation of contrast. So the curve here is different, right? Instead of dipping down, it tends to go up. This example actually is an interesting one because it was called hemangioma. And this is really the type of example where you cannot call it hemangioma because there is no nodular enhancement. The peripheral enhancement is a rind of tissue, right? It's not multiple nodules. So calling that hemangioma is not possible. Now on the delayed, sure, I mean, it's filled in, so we could argue that it could be a hemangioma. But it is, if we apply the strict criteria, we know it's not a hemangioma. And again, it's one of those adenocarcinoma with persistent enhancement on the delayed images. Another example of metastatic colon, pretty typical. So here you have some enhancement on some of the metastases on the early phase. Then you see them better, that's the typical portal phase. And then eventually on the delayed images, there is central enhancement of the tumor and then a subtle rim of hypoattenuation. So the same as the case I showed earlier, there is accumulation of contrast on the delayed images. And as with the breast case, to some extent, you lose the disease. You don't see it anymore on the delayed images. Another example of the same. This is clearly seen on the non-contrast, difficult to measure. So it's a case where you would argue that if you are going to follow this patient on treatment, you want to have the non-contrast because that's the only time you really have an idea of the size of the tumor. The other phases are more difficult, and of course, on the delayed, it's completely gone. So schematic representation, again, they can be hyperdense to the background. They are often not, or iso or hypo. They accumulate contrast on the delayed images. If they do not accumulate contrast, they don't lose contrast. They remain enhanced over time. And if we do the more scientific approach, measuring the attenuation value, you see that all these curves tend to go up. They are different from the peak and loss of contrast that I showed you with the HCC. So usually hypodense in the background can be hyperdense. The key is the accumulation of contrast over time. So I'm just showing you a couple of cases of too small to characterize to show you that this principle can be applied in any tumor size. This is a patient with a vascular ring enhancing nodule here. We see it on the next phase, and on the delayed, that lesion, it's not really delayed, the portal phase, that lesion is hypo. So we know there is loss of contrast washout. This cannot be a hemangioma. And this was a patient with a history of hepatocellular carcinoma, and that was recurrent in the liver remnant. This case is a colorectal carcinoma patient. The portal phase shows this little nodule hypoadenuating. So if we only have that, we can say a small nodule could be a met, right? We don't know what it is. But if we have a multiphasic study and we have a non-contrast, non-contrast is bigger than on the portal phase, and the delayed images, non-delayed images, there is an area of enhancement that correlates to the same location, then we have the same pattern, right? It's hypo on the portal phase, but it's hyper on the delay. There's been accumulation, and the size of this area of enhancement is similar to the size that we have on the non-contrast scan. There's one other case. It's also a patient with colorectal. This one is a bit bigger, and there's a little dot in the middle. So is it a hemangioma? We will know maybe if we have the delayed, but not necessarily. But if we have, the pre, we see calcification. So in this case, the little dots are not areas of enhancement, nodular enhancement, they are calcification. With that, calcification in the liver of a patient who has colorectal disease, we know that it can be a metastasis, and it is a metastasis. Okay, so those are kind of quiz cases. I'm going to give you a little bit of time to look at it. So there are multiple lesions. Just try to see if the pattern of enhancement is the same in the left liver and in the right liver. All right, so if you look at this tumor here, diffuse enhancement, if you look at this tumor here, ring enhancement, this is a little bit different. That doesn't mean necessarily too much, but it's different. If you jump to the delayed images, this tumor here is hypoadenuating. So all the contrast that was here is gone. On the other hand, the one I was re-enhancing, now there is persistent enhancement. So this is the pattern of HCC. This is the pattern of adenocarcinoma. So it's a patient who has both type of tumor at the same time. What about this one? So there is one tumor here, and if we try to characterize it, is it an adeno or is it an HCC? Is it something that retains contrast or something that loses contrast? And again, there is a different pattern. So on the arterial phase, you see that there is enhancement along the entire aspect and not much posteriorly. The posterior portion of the tumor remains kind of hypo, right, on all the three phases. But when we go to the delayed phase, this area is now packed with contrast, right? This one, on the other hand, there is enhancement. And then on the portal phase, there is decrease. And on the delayed phase, there is more decrease. So it's a little bit difficult, but you can see that we go from something that is hypo of fairly large size to something that is hyper, or at least mostly enhanced. While here, there is a lot of enhancement, which we lose on the portal, on the delayed phase. So again, this is a mixed tumor with a component that is behave like HCC and a component that behave like an adeno. So those two patterns, as I said, are helpful about 2/3 of the time. With HCC, the typical hypo pattern is seen in about 60% of the cases. What will impact the finding is the size. Small sizes are less typical, and the differentiation only with well-differentiated tumor washout is only in 50% of the cases. And of course, there are many variants like sclerosing hepatocellular carcinoma or tumor where the tumor that ends up in the bag of indeterminate. And then the cholangio The vascularity is also linked to the differentiation of the tumor. Some of the cholangio do wash out. So those generally end up with being tumors that are fully differentiated. So this is an example of an HCC that does not follow the rules. This is hyper, and this is still hyper. There's no washout on the delayed, and yet this is a patient who has an HCC. This is the same thing. This is a case of an HCC which doesn't really behave like an HCC. In fact, if I see this case, I'm going to say this is an adeno, but the biopsy showed that it was an HCC. So those tumors do not follow the rules and are very difficult. And this one is an adenocarcinoma that I would call every day, or at least I would suggest that it's an HCC because there's so much washout on the delay. There's even vascular invasion, but this is a poorly differentiated. So the moment the tumor are fully differentiated, it becomes really more difficult. So conclusion. The technique. That's what matters the most, because if you have lousy images, you can get all the consults you want. There is no diagnostic possible. And the dose in oncology is irrelevant because the life expectancy of this patient is not sufficient to expose them to any risk. In addition, the toxicity of what we do to this patient in terms of chemotherapy, for example, is really much more toxic than radiation from diagnostic imaging. The importance of the non-contrast, and an importance to remember that we don't know what we miss. For the characterization, the delayed images are capital. The non-contrast can be very helpful, like the case I showed you is a small calcified met from a colon. And of course, comparison with everything else we have. The older scan are always making us smarter, as we all know. The characterization is obvious because the tumor behaves as it should. So we have a high level of confidence of its nature, but we have to be extremely careful not to overcall. And then for the malignant tumor, two big categories: the category that is very cellular and is generally very vascular, and the tumor that has a lot of fibrosis and is usually classified as hypovascular in spite of the fact that they do enhance. So pattern enhancement is going to be affected by the size and the differentiation. That's it. So if you have questions, I'm happy to answer.
Thank you very much, ma'am. That was a very illustrative and very well explained topic on CT differentiation of various hepatic tumors. If you don't mind, there are a couple of doubts we have got and we'd like to